Hello, my name is Vignette, and today I'll present a 7 to 10 minute clinical vignette on schizophrenia spectrum disorder. This case demonstrates evidence based assessment, differential diagnosis, and pharmacological and non pharmacologic interventions aligns with NICE guidelines from 2023 to 2025. Okay, let me introduce you to Mr. James R., who is a 24-year-old male who presents today saying, "The voices are louder again, and I can't focus at work." James' symptoms began gradually about 2 years ago, with increasing social withdrawal, poor motivation, and subtle changes in his thought process. Over time, he became more withdrawn, stopped engaging with friends, and began responding to internal stimuli, often seen laughing or mumbling to himself when alone. He was diagnosed with schizophrenia at age 21 after his first psychotic episode, which required brief inpatient stabilization. He was started on risperidone 3 mg nightly, but he stopped taking it 3 months ago due to sedation and significant weight gain. Since stopping the medication, his hallucinations have worsened, and his functioning has declined. James currently lives with his parents and is unemployed. He reports difficulty concentrating, fragmented sleep, and poor appetite. His family describe him as quiet and withdrawn, often spending most of his days in his room. On initial evaluation, James appears disheveled and has poor eye contact. His speech is coherent but tangible at times, tangential at times. He reports hearing two distinct male voices arguing with each other, but denies that the voices command him to act. Importantly, he denies any suicidal or homicidal ideations, though he occasionally glances toward the corner of the room as if listening. Overall, this is a relapse presentation of schizophrenia, likely due to medication non-adherence, and his case highlights the importance of medication management and patient education in long-term psychotic disorders. So James denies SI or suicidal or homicidal ideation, but occasionally expresses passive thoughts of worthlessness. He has poor insights into his illness and experiences social withdrawal and disorganized thought processes. Physical exam and basic labs are unremarkable, and urine tox screen is negative. When evaluating James, I considered several differential diagnoses before confirming schizophrenia. First, I thought about schizoaffective disorder, since it also involves psychotic symptoms like hallucinations and disorganized thinking. However, schizoaffective disorder requires mood episodes such as major depressions or mania that occur for a significant portion of the illness, and psychosis may also occur for at least 2 weeks without any mood symptoms. In James' case, he denies any prolonged depressive or manic periods, so schizoaffective disorder is unlikely. Next, I ruled out substance-induced psychotic disorder because drug use, particularly cannabis and stimulants, can cause hallucinations and paranoia in young adults. James' toxicology screen was negative, and his symptoms have been persistent, not temporary or linked to substance use, which supports a primary psychotic disorder instead. I also considered delusional disorder, but that condition usually involves one fixed delusional belief with relatively intact functioning. James' presentation includes auditory hallucinations, disorganized speech, and significant social and occupational impairment, which go beyond delusional disorder. Overall, based on the chronic duration of symptoms over 2 years, functional decline, and the presence of both positive and negative symptoms, James meets the DSM-5-DR and APA and criteria for schizophrenia spectrum disorder. Based on current APA and NICE guidelines, second-generation antipsychotics are recommended as first-line therapy for schizophrenia due to better tolerability and lower risk of the EPS symptoms or the extrapyramidal symptoms compared to first-generation drugs. For James, I selected aripiprazole, commonly known as Abilify, as a first-line medication. The usual starting dose is 10 to 15 milligrams orally once a day. can be titrated up to maximum of 30 milligrams if needed, depending on symptom control and tolerance. Abilify mechanism of action is unique. It acts as partial agonist at dopamine D2 receptors and the serotonin 5 receptors while antagonizing serotonin 5 receptors. This balance helps stabilize dopamine activity in key brain pathways, reducing hallucinations and delusions without causing the dopamine blockade, side effects that often lead to stiffness or sedation. I chose Abilify specifically because James previously discontinued risperidone due to sedation and weight gain. Compared to risperidone, Abilify has a lower risk of metabolic effects such as weight gain, elevated glucose, and dyslipidemia. It also has a long-acting injectable form, which can be considered later if adherence continues to be an issue. This is important for patients like James who has a history of non-compliance. However, it's important to discuss possible side effects such as mild restlessness, insomnia, and akathisia. I would advise James to take the meds in the morning if he experiences sleep disruptions and report any excessive restlessness. Monitoring including weight gain, BMI, fasting glucose, lipid panel, and the EPS symptoms using the AIM scale. Regular follow-ups are scheduled to assess adherence, efficacy, and tolerability. If James doesn't respond adequately, there are options that are available, such as risperidone, paliperidone, cyclonide agents for treatment-resistant schizophrenia, defined as non-responsive after 2 adequate antipsychotic trials. Clozapine remains the gold standard despite its need for blood monitoring due to a granulocytosis risk. In summary, Abilify was chosen because it aligns with guideline recommended care, balances efficacy and side effects profile, and support James' need for medication with fewer metabolic complications and better adherence potential. So, for contraindication monitoring, it's important to monitor for weight, metabolic labs, and EPS symptoms. Educate patients about early warning signs like akathisia, which can be managed by dose adjustments or propranolol. So the evidence-based guidelines strongly recommend combining medications with psychosocial interventions because it improves coping skills, family involvement enhances adherence, and telehealth check-ins provide early intervention for symptoms relapse. Patient education is essential. I explained that antipsychotic helps regulate brain chemicals and skipping doses can trigger relapse. James was advised to maintain consistent routines, good sleep hygiene, and avoid alcohol and cannabis. At follow-ups, James improved but reported restlessness, likely akathisia. Propranolol 10 mg BID was added, and therapy attendance was reinforced. Next follow-up scheduled within 4 to 6 weeks. In summary, James' case illustrates the importance of combining pharmacological and psychosocial strategies using evidence-based interventions. Telehealth follow-up and family support ensures the care and relapse prevention.